Farah campus. We are transmitting to you live, and the backslide is the Dead Sea in Jordan, which is the lowest point on Earth. The theme for today is the Transtentorial Epidermoid tumor, and we'll go for the correlation that we all know now. When we say transtentorial, what do we mean? This is the tent separating the posterior fossa from the supratentorial compartment. So any tumor that goes through that opening that transmits the brainstem is called the transtentorial. So the tumor is above the tent in the supratentorial compartment, here in the temporal area, and here it is in the posterior fossa. Transtentorial. Again, like here, tumor is in the posterior fossa and going through the tent into the supratentorial compartment. That's what we mean by transtentorial. As in here too, this is the tent, and this tumor in the posterior fossa, and this tumor is in the supratentorial compartment. So what is the tent? Tent is this dura, which is also this dura. This is called falx cerebri, separating right and left hemisphere, and this is a folded dura, which is separating the supratentorial compartment from the infratentorial compartment. It is called a tent because it is really like a tent. It is pulled down. So falx cerebri, tentorium cerebelli. Same here, falx separating right and left, and this is the tentorium. Underneath it is the posterior fossa, and above it here is the occipital lobe, temporal lobe, and frontal lobe. Again, this is the tentorial notch, or the opening through which the brainstem passes. We have the spinal cord coming down through foramen magnum, and then becomes medulla, pons, and then midbrain, and midbrain passes through this hiatus, or opening in the tent. This is the tent here. We have removed it this side. So tent here, this is the straight sinus, this is the tentorial notch, this is the brainstem, substantia nigra aqueduct, and third nerve. Stem passes. So tumor will pass through this, and it's a very critical area. Now, what about epidermoid? People call it epidermoid cyst. It's no more called cyst. We have to stop saying cyst. And I've seen neurosurgeons telling their patients, case of the nishaba. This is nonsense. This is a very bad tumor, very hefty tumor. It is a congenital neoplasm, and it's called inclusion neoplasm. As we are developing third, fifth week in gestation, the neural tube, some inclusion would occur, and the epidermis would be included inside and cause the epidermoid, different from dermoid, whereby dermoid tissues are present. It's made of stratified squamous epithelium, which secretes this. This is keratin, coming out like onion, desquamation. So this is not the important issue in these tumors. This is the important issue. This is the one that secretes this. So inside there is keratin and lipid. Where does it occur? The most common locations are cerebellopontine angle. These tumors are very intelligent, they are very sneaky, they are very devious. They go into places to protect themselves. They go into the darkest points in our brain to hide. So they are not easy tumors. Followed by paracellular, supracellular, ventricular system, and others. But the commonest is the cerebellopontine. They are rare, constituting 0.2 to 1.8% of all intracranial tumors. And they can happen from birth till 85 years. Children, infants, adults, everybody. But the commonest age is this. It is very rare in children. And this is a study from Hospital for Sick Children in Toronto. During this period, 80 to 2007, 27 years, they have only found 7 cases of pediatric epidermoid. So these are different sites for epidermoid. They can occur anywhere in your or my brain. And the images that we see in these tumors, if you do skull X-ray, you may find some erosions. So epidermoid tumors cause erosions. They are hefty tumors. They're not easy ones. Look at here and here, destruction here. This is epidermoid within the bone. Epidermoid within the bone, destroying it. So you can see the tumor itself. It's a hypodensity, and the CT scans. These are CT scans which I collected over the years. I think one of them, what is it? This one is back in 1982 when I was still in training. MRI, hypointense on T1, hyperintense in T2, no or marginal enhancement. So that's the teaching about these tumors. So T1 with contrast, flare, T2. And then you do the diffusion, weighted. Again, you can see these changes. The so-called white tumors on diffusion. And this is the most important single image that one should do for these tumors, the diffusion and the ACD map. Again, looking at here, for contrast, after contrast, T2, and then the diffusion. And diffusion will tell us whether we have done a good job or not. This is pre-op, and this is post-op. This is the only way of telling that we have removed the tumor completely. What kills me is that in Jordan and in the Middle East, epidermoids are given to the least experienced resident in the team. No, this is epidermoid, go and do it. It's nonsense. It is the most difficult tumor, and it should be done by the most senior. MRA is needed, and I consider MRA and MRV are part and parcel of the MRI. This is a tumor, transtentorial, going into the temporal, and look at the elevation of the middle cerebral artery. MRV is important. This tumor is centered on the vein of Galen. We don't see the straight sinus at all, and we don't see vein of Galen. They can invade and close these veins. They are hefty tumors. This is a tumor. This is the confluence of sinuses. Superior sagittal sinus, left straight sinus, right straight sinus. This is a tumor which is blocking completely the right transverse sinus. Again, the same here. This is MRV, and you can see also that it is closed. And this is how it looks. This is one of the epidermoids blocking the transverse sinus. This is an opening, removal of the contents, and you come to see the transverse sinus. This was a wife of a surgeon in here in Jordan. They can come in association with many diseases, aneurysms, meningiomas, gliomas, so we forget about these associations. This is a paper, coexistence of epidermoid with multiple aneurysms. This is one of my cases, association with meningioma. This is the epidermoid, and this is the meningioma. Again, here is the epidermoid, and here is the meningioma. This is one of my cases. You can get them in a small size, you can get them in a giant size, because they are slowly growing tumor. They are devious, they are intelligent. They just go slowly so that you will not pay attention to their presence. Very devious. In fact, I think of them as intelligent a human being. And this is one of my cases. This was reported as a giant one. I respond by saying this is one of the real giant ones of epidermoids. Another giant, case of mine. Another giant, and this 29-year-old female Jordanian. Really giant. This is in the fourth ventricle. Again, another giant, before and after. Sometimes they come as atypical. The definitions that we gave is not a must. This is an epidermoid. This is T1 okay, T2 okay, but then it does not restrict on diffusion. So epidermoid not restricting on diffusion. It can happen. This is called atypical. This is the histology.
Are they usually encapsulated or are they just diffused?
We'll see it in the film. Atypical again, and there is no diffusion, although it is epidermoid. Again, the same thing here is with contrast. We say they don't contrast. This is a case with contrast. Again, one of my cases, contrast here, there, there. And this is also one of my cases. This is really a major surprise. When I went in, I thought I'm dealing with pituitary adenoma, and then it turns out to be an epidermoid. Everything against what the epidermoid looks, either in T1 or T2 or with contrast or whatever. This is before and this is after.
This is white epidermoid?
No, this is contrasting epidermoid, which is very funny. Again, the usual teaching that they don't calcify. There are cases where there is calcification. Again, major calcification, not minor ones, major ones. Look at here, the contrast and the edema. Usually they say they are not associated with edema. Here it is associated with edema. Can they rupture? Yes, they can. And when they rupture, usually they are fatal or cause severe meningitis. This is the thing that ruptured, and this is the fat tissue disseminated through the subarachnoid spaces. This is one of the cases reported, and I respond by giving you one of my cases, like this. They give meningitis-like syndrome or subarachnoid-like syndrome, and the importance that they will cause adhesions later on. Again, one of my cases, this 23-year-old man from the West Bank of Georgia, Palestine, and you can see the aneurysm is ruptured, and look at the fat droplet distributed in the subarachnoid space. They can rupture spontaneously or after trauma. And this is the operative images of that boy, and you can see this is optic nerve, carotid, and this is the third nerve. You can see the droplets of fat distributed, as if you are swimming underneath the sea and you see weeds. And this is the list of the reported cases of ruptured epidermoid. Can they turn malignant? Yes. Benign tumor, they can turn malignant. And they call epidermoid carcinoma, either de novo or on top of a benign ling. And the serious thing that there is no tumor markers that can tell you. This is one case of reported carcinoma that looks like benign, but it tends to be malignant. And another case, after treatment, it came back and increased malignant. And these are the list of the malignant formation of these tumors. So they are real malignancy. As I said before, they are very intelligent, they are sneaky, and they are misleading. They don't push things. They wrap themselves around the things, roots or nerves or vessels, and they take these vessels with them wherever they go. So they look into the darkest places in the brain. Look what they do to the stalk, stretching it very much because the tumor is there. Look at the optic being elevated. Here, you can see the optic has been elevated. Third nerve, you can see it is stretched, going into the roof of the cavernous sinus. Look at the trigeminal, twisted, tortured. So you don't find nerves where you expect them. They will be somewhere else, where you do not think that they will be there. Sixth nerve, here at the clivus, at the Doralis canal. They go into the internal digitatus, or they just lift 7th and 8th. They go into the jugular foramen and the hypoglossal canal, into the jugular. They go into the hypoglossal canal, and this is the tumor And this is the hypoglossal nerve that we don't see. This is 9, 10, 11 going to the jugular foramen. And after you remove them, you can see the hypoglossal nerve. They push the vessels like this. Look here, this is posterior cerebral. Here is the precom. They are distorted. Again, basilar and superior cerebellar. Look at the vertebrals being pushed. Again, posterior cerebral. Here is the terminal basilar being pushed up. Same here, both basilars are pushed. Here is very unique. These are two internal cerebral veins with all the joint veins from different parts of the brain. Look at them, how they are pushed and how they insinuate themselves. Cisterns, they go into cisterns. They fill the cistern, ambient cistern, quadrigeminal cistern, and all the cisterns that we know of. Look at here. So what's the differential diagnosis of these lesions? It's not easy. I put them in questions. Is this arachnoid or epidermoid? This is epidermoid. And as I said, we're back to diffusion. Diffusion will give you white tumor in diffusion. Is this a glioma or epidermoid? When I had this Yemeni patient, I thought this is a glioma. When I went in and excised it, it turned out to be an epidermoid. Glioma or epidermoid? Epidermoid. Trigeminal schwannoma or epidermoid? We have seen trigeminal schwannomas previously here under this roof, and you can think that this may be trigeminal schwannoma. It turns out to be an epidermoid. Again, trigeminal schwannoma? No, it turns out to be epidermoid. Cavernoma or epidermoid? Would one miss this? So obvious. Cavernomas are very well seen, popcorn appearance, hemosiderin, etc., etc. This turned out to be an epidermoid, although it looks like a cavernoma. And this is one of my cases. A man, Jordan man living in Qatar, and he came to me and he said, oh, this is cavernoma. I went and removed it, and it turned out to be an epidermoid. Hemangioblastoma, oh, cyst with small nodule. No, this is epidermoid with calcification. Cholesteatoma or epidermoid? Epidermoid. Craniopharyngioma extending to the posterior fossa or epidermoid? Epidermoid. Teratoma or epidermoid? Epidermoid.
You can still have crystal cholesterol.
Yes. This is histological proof, because these are cases, real cases, confirmed. This is not a mental exercise. Highlighted or epidermoid? This was highlighted. Is this arachnoid or epidermoid? When I went in, I was in doubt. I was not sure, but it turned out to be an arachnoid in this man from Jerusalem. Cholesterol granuloma or epidermoid, we mentioned this is cholesterol granuloma. Cysticercosis, very much like the things that we have seen. It is forgotten disease. We don't think of parasitology. Neuroenteric cyst look like epidermoid or arachnoid. No, it turned out to be an enterogenous cyst or encephalic cyst or epidermoid. Turned out to be a porencephalic cyst. Choroid cyst or epidermoid. This was a choroid cyst. Neuroglial cyst or epidermoid was a neuroglial cyst. Ependymal cyst or epidermoid. And this Iraqi man, he came to me and I did not know what it is. I went for exploration and it turns out to be an ependymal cyst. So, differential diagnosis is very, very wide. How should we treat them? Conservatively or by surgery? If the symptoms are minimal, you go for conservative. If the symptoms are major, you go for surgical. And this is one of the cases. Came to me with mild trigeminal neuralgia. She was already on Tegretol, 1 tablet, and I followed her from 91 till 11, no change, and she was completely free of symptoms on 1 tablet of Tegretol. So why should I bother operating upon her? This lady came to me in 2009 with this epidermoid. Again, minimal symptoms. So we waited. 2010, no change. 11, no change. 13, not a single change in her symptoms or signs. 2014, she was still doing well, and I did not operate upon her. So you can go for surgery, and if you go for surgery, you have to radical excision, not just to suck the contents. And we will see this, Marwan, on the videos. This is Paul Posey back in 1931. What did he say? Some 100 years ago. It is important that the wall of the tumor, which is the capsule, which is the only living part of the tumor, be removed completely in order to prevent recurrence. Just to suck this keratin inside is nothing. Simple evacuation of the contents will not suffice. 100 years ago. And then Osama al-Mufti, a Syrian surgeon, very famous in the States, total removal of the capsule and the contents of the tumor can be achieved in the majority of patients. This will minimize recurrences, this will minimize malignant change, and this will minimize repeated surgery. That there is no cure. Once they recur, there is no cure. They are not radiosensitive, they are not chemosensitive, so the only way is to do surgery. And if the tumor recurred because you did not remove them well, usually recur back in 6 years' time. Note this, notoriously difficult to reoperate, virtually never curable. So what is the prevention? Total removal. That's why it should be done by the senior neurosurgeon. Why should we go for total resection? So that because they are not radiosensitive, to prevent recurrence, to prevent rupture, to prevent malignant change, and to prevent aseptic meningitis. These are the cases where the partial removal and the recurrences by the authors. So even in the big shots, like Simon, Sami, Landry, all these people, they have their these are recurrences in my series. Removal, total removal, and they recurred. Another case, a lady here from Jordan, and again the total excision, and it recurred. So even if you do radical excision, they may recur. What about if you leave something? So you should do everything you can to take them completely out. And if you remove them, there is a question on some cases, 21 cases with post-operative hemorrhages, because you are leaving a big space and there might be some hemorrhage inside the space. Anatomy, how do we operate? We operate according to the site, either retrosigmoid or pre-sigmoid, or we go through middle fossa. So different, here we go elevate the temporal lobe and go underneath it, subtemporal approach. So you come to the tent and you come to the side of the brainstem. You see the basilar and you see the superior posterior cerebral and superior cerebellar arteries. So this is the position of the patient. And you go and you open the forks so that you will go through the tent. You open the tent so that you go underneath the tent to the posterior fossa. And once you do that, this is the tent, and you will see the fourth nerve and you will see the trigeminal nerve. Very beautiful surgery if you know the anatomy. So back to epidermoid tumors. Epidermoid. This is the French anatomist who described them first back in his time. And he called them pearly tumors, like pearls. Al-lu'lu'. They're beautiful, but they are bad. Dandy, the father of neurosurgery, he called them the most beautiful tumors in the body. Again, they are pearls. They really look like pearls. And pearls, as you know, you have to swim under the water to go into these places where these pearls are present. Whenever there is deep water which is hidden, you can find pearls there. So the most famous word related to the pearls is Pearl Harbor. This is in Hawaii, and this is one of the islands. And look at this place here, dug deep. You look at the color of water; it's very deep. So it used to be called Pearl Harbor because the locals were used to dive and fish for the pearls. Pearl Harbor. But Pearl Harbor came to acquire a very infamous history. So this is the United States, this is Hawaii, these are the 4 main islands of Hawaii, this is one of them. And this is one of them, as I said, the islands, and this is the Gulf, the harbor. And this is called Ford Island. Why am I mentioning this? Because back in 7th of December 1941, the Japanese army attacked the fleet of the United States here in Pearl Harbor. We know Japan is away something like 3,500 miles. But they sneaked, they sent their carrier aircrafts, and they went close to the islands, about 250 miles, and then the airplanes got out from the carriers and they hit the whole of the fleet of the United States of America back in 1941. Let's see the film, just to change the mood.
Are they hard tumors as a way to kill them?
Sorry?
Are they hard tumors? Hard?
I will answer all your questions.
Planes coming in from the north, 140 miles, 3 degrees east.
Yeah? Well, don't worry about it.
Called Tora, which is the code name to start the attack. Let's see the very next day, Franklin Roosevelt, the President of the United States, made this
Yesterday,
speech.
December 7th, 1941, a date which will live in infamy. The United States of America was suddenly and deliberately attacked by naval and air forces of the Empire of Japan.
So he's continuing with his
The United
speech.
States was at
He asked the Congress to announce or declare war on Japan, which they did on the same day, and then the Second World War took some time. Okay.
Which was at the end agreement between USA and Japan to attack them to justify the war. The
Exactly.
same what happened with
Okay.
Iraq.
Now let's-
Exactly the
They
same.
knew they were
the same
going to be
story.
attacked.
Exactly the same story.
They knew they were going to be
Okay,
attacked.
now this is the tumor. We are
They
attacking
invited
the
them.
tumor in the posterior fossa,
Yes,
and this is for humor one.
yes, yes, yes.
We are opening the arachnoid here, and this is the tumor, the most beautiful, awkward tumor. It just trapped itself around the vessels, and so these are the contents, the keratin. These are not important. The important is to remove the capsule of the tumor. So in addition to removal of these, which obviously are soft because it's difficult to hold them, they're just like cheese, Marwan.
Oh, they are, huh?
Yeah. So not enough just to suck the contents. Now we have to, within this yellow, white color, you cannot identify nerves. So nerves are the most that can be injured. You have to take this capsule out. So all is important to remove these. This is facial nerve going to the tendinomeatus or working underneath. So you work in between the nerves. And the brainstem is here, tendinomeatus is here. So you have to manipulate these things and remove them from the attached to the vessels and so on.
Oh, they're almost identical in color.
Difficulty. So this is the tent, and the tumor is going through the tent. You have to go slowly, you have to know your anatomy, and you have to anticipate where would the nerve be from the MRI and so on. So studying the MRI beforehand is very important. What happens is that this is given to the most junior resident, and he doesn't know anything about anatomy, he doesn't know anything about radiology either, and they just get stuck. Simple surgery, or not simple, good surgery tends to be disaster. So you go slowly between vessels.
What are you doing here?
I'm taking the tumor away from the facial nerve and pica. Separate them, and then I'll go above that into the trigeminal. Here we're going through the tent. This is the hiatus here. This is the tent I'm pulling here.
Where's the facial nerve?
The patient is sitting position.
That facial nerve, where?
Facial nerve was here. Yeah, when you were talking
Yeah.
outside, we saw it. This is vein of Dandy, superior petrosal vein, going into the superior petrosal sinus. Facial nerve is somewhere here. Trigeminal is there. So you can see they are adherent to the nerves. This is the superior petrosal vein. It is standing in the way, so I cut it. And then I proceed to see there the trigeminal nerve. So the facial is here, vagus is here. And again, you just continue to proceed. You remove the contents so that you will reach to the capsule, and the capsule is attached to the arachnoid, so remove the arachnoid and the capsule. This is the only way to prevent recurrence. There is the sixth nerve in the Duralis canal. Here we are separating the tumor from the midbrain. Look here at this vessel embedded inside the tumor. You have to be intelligent and see where did it go. Look at these branches inside. It's not easy at all. These are the perforating branches from ICA going into the brainstem. So it will cause brainstem infarct. Look at this vessel here. Here's the facial and pica. This is the tentorium. This is midbrain. Again, look at these vessels, how they are. It's a nerve-wracking kind of surgery for the person who knows the anatomy. It's nerve-wracking. For those who don't, he doesn't care. You just remove some of these keratin things and they say we have decompressed. The word decompression is used in a big way in our lingo here in Jordan. We have done decompression laminectomy, we have decompressive craniotomy, we have done decompressive whatever, which is always false and misleading, to say the least.
So you're dissecting and suctioning at the same time?
Yes, yeah, I'm sucking the keratin contents, which are suckable, and then I'm looking for any attachment to nerves and things, and then again look at here the attachment to these veins here. Now going through the tent, we'll come across the stereocerebral and cerebrocerebellar artery. That's the removal of the capsule. You have to use sharp dissection, use scissors. This is the trigeminal nerve going into Meckel's cave. And the tumor usually likes to go to Meckel's cave. They like caves. They like to hide. I'm elevating the trigeminal nerve, going underneath it and above it. Facial is here, vagus is here. So here I'm removing the capsule with the arachnoid. And we keep watching so that will decrease the fat content. This is trigeminal, this is facial, and here is the facial. Jugular foramen is here with the 3 nerves, and above there is the trigeminal. And then you come out and wash and so on. Okay, let's see the one. So this is for the posterior fossa part. As you know, we are dealing with the tumors that are in the posterior fossa and in the above. That is not good. Here we are using the subtemporal approach. We are elevating the temporal approach on the right side, and we are going in to remove the tumor. Again, I'll proceed for the sake of time. These are contents which I'm not bothered about. I just want the space.
They don't get any facial palsy or anything like that?
Yes, of course, they can.
They can?
Of course. Because the tumor is attached to them, and sometimes the little small capillaries can cause damage to this. So one of the complications of this surgery is facial nerve palsy or hearing loss and so on and so forth. That's why it should be done by an expert surgeon and not mine. Here we're removing this, and then we'll come to the tent itself. I'm not going to bother you with the details, but just to show you that I'm opening the tent here, so that I will go into the posterior fossa. So whenever I'm going the posterior fossa, I like to go through the tentorial hiatus, and if I'm going from the middle fossa down to the posterior fossa, I open the tent like this and go into the posterior fossa. You have to know where to open and so on.
Saw this with a microscope, right?
Yes, of course. It cannot be done without microscope. So the tent is open and you are looking at the posterior fossa, the cerebellum and the brainstem, and everything there. This is the tent, which I'm cutting. Cutting it will cause no problem. Look at this here. How the tumor is attached to the brainstem, to the cerebellum here. Look how it is attached to the vessel. This is the stereocerebral artery. Sometimes just manipulating the arteries will cause them to go into spasm, and spasm will cause neurological deficits. Here is the trigeminal nerve, as seen from above. You see here is the removal of the capsule, completely, not the contents.
Is it a vascular tumor?
No, but it is attached to main vessels. So we have removed the middle fossa, we opened the tent, we went into the posterior fossa, and we removed the tumor of the brainstem and the cerebellum. And here is the continuing opening of the tentorium. And once you open more, you will find more.
So the capsule doesn't come out as one piece, you still have to go back in and...
Absolutely, piece by
pieces
piece, yeah.
out.
This is the posterior cerebral artery. And then the end of it, okay. So I've shown you two films to show you the posterior fossa component and the middle fossa component. My series, 126 cases, although they are rare, I was lucky. Between 85 and 17, 113 were intradural out of 26, 6 were extradural, 4 were in the spine, 3 were in the orbit. So spinal is much rarer than the cranial, it's 10-1, cranial to spinal, and this is one of the spinal cases. This is one of my cases, and another one. This was a lipoma and epidermoid, which is a common association. Extracranial like this, it's extradural. Extradural. Petrous bone, epidermoid. And this is one of my cases. Orbit. Cavernous sinus. They like caves, they like the hidden places. They are extremely intelligent. Cavernous sinus, and this lady from Libya, before and after surgery. Again, cavernous. Cellular tumors, just within the cellar, before and after surgery, histology. Cellular. And this young boy here from Jordan, another cellar again, or they can go into the third ventricle, from the cellar into the third. This is the lamina terminalis approach, optic nerve chiasm, and we open the lamina terminalis. Supracellular, like this. Again, this lady from Libya, and the supracellular before and after. All of them are documented, and this is paracellular. And I always say, the best anatomy you can see after removal of the epidermoid. Once you remove them, you'll have a good, big, huge space. Look at this here. This is magnificent view. This is the basilar artery, and this is the superior cerebellar artery and posterior cerebellar artery. And this is the third nerve coming in between them, going into the roof of the cavernous sinus. You would not see this anatomy anywhere else. Again, this paracellular tumor, before and after. Or in the cerebellopontine angle, this young girl here from Jordan who came with the sixth nerve palsy. And she was treated with eye drops. And she was thought to be maybe diabetic. She was not. So just eye drops would suffice. Any patient with sixth nerve palsy, young, think of cerebellopontine angle lesion. Any patient young with hearing loss, think of an acoustic neuroma. Don't think of wax. So we did her surgery and we followed her up, and she got married, and I was invited for her wedding. Another CPA angle going into the hypoglossal canal, as I mentioned, before and after. Tumor could be completely prepontine. This is prepontine of my patients before surgery and after. They could go into pineal. They love to go into the dark places. This is pineal, before and after, and the follow-up. Again, pineal, before and after, before and after. You can see this is mucky, dirty, or this is a clear CSF. And the only way to see a pineal gland is when you are dealing with the pineal tumor, with the epidermoid in the pineal area. After you remove it, this is your only chance to see a pineal gland. This is the pineal gland. This is superior colliculus here, inferior colliculus, and then the pineal. Tumor around it, you remove it, then you can see it. It could be totally within the ventricle, inside the fourth ventricle. Tumor, start removing it, and then you see the midline raphe and the transverse raphe. It could be in the fourth, going through foramen magnum. So this is transforaminal. Or, as we said, it could be transtentorial, as we have seen, going through the tent. And we do it in two stages, as I mentioned. This is first the tumor. We've done the first stage, which is either posterior fossa or the middle fossa, and then you continue with the second stage and complete removal of the tumor. And this is the patient, before, during, and after. Follow-up, 8 years, no recurrence. Another transtentorial, before and after. And this young man from Iraq, Kurdistan, with this tumor here, he presented with epilepsy, his main presentation. So our case for today, which I'm going to go through very briefly, because we've discussed everything. This is a 33-year-old female from Syria, and this is back in 2005. She complained of headaches. And we, in the Arab world, in the Middle East, and the Third World, we do not pay attention to headaches. You ask the patient, did you have headache? Mild headache. And the ones that if you take 2 Panadols, it will go. So it's not important. It is. Panadol that is there every day or every second day is very important. And what was she diagnosed as? Migraine. Migraine is an undercover diagnosis for everything. So long there is some neurological deficit, this is migraine. And he's, oh yes, so long he's young patient. And once you label patient as migraine, nobody can change it. Khalas, migraine. This is a migraine patient. Khasa is a big hospital, like big hospitals in Amman, where they see 100 or 200 patients per clinic. So the 1 year before admission, she had severe headaches, and then she started having blaring of vision. Vital signs were okay, general examination was okay, she was worried and anxious. No cerebellar signs, fundoscopy, no papilledema or atrophy, no weakness in her upper or lower limbs. All investigations were normal, and this is her images. So the tumor starts low down at the level of the medulla, goes compress the pons, goes to compress the brainstem, go through the tentorium, and goes up. So here you are. So it went up into the temporal area. So we did a few consultations. Dr. Mahmoud Asad saw her for tympanogram and audiometry. They were normal. Dr. Ibrahim Nawasi saw her and he did not find any positive findings. And this is her visual fields. But this is out of a holistic approach for the patient. Everything should be done for the patient. And the anesthetist then was Dr. Muawiyah Babni in Jordan Hospital. And the patient was considered fit for general anesthesia back in 2005. And we have done the first surgery, which is the posterior fossa first. And then we went into the subtemporal, like the ones you have seen. I'm not going to put the film for this one. And this is the post-operative after the first surgery, mainly concentrating on the posterior fossa. We removed the posterior fossa part. We followed her 7 months later, and we know that she still has this temporal part, so we went for it, and we did surgery for her, and this is the post-operative MRI. Dr. Hassan.
So according to Dr. Ibrahim, these are the most beautiful tumors in neurosurgery, but for the pathologists, these are the ugliest tumors because they have a very bad mousy odor when we do the gross on them, and they soil everything. So we try to avoid working on them until the end when we do the gross examination. So as you can see, this is the tumor. You can see the squamous epithelial lining, and all this is the keratinous material that becomes desquamated and fill the cavity of the tumor. This is a higher power view, yes. Just to show you the benign squamous epithelium, which is stratified. This is the keratin, and here, and you can see here there is a granular layer, which is maturation, and then it becomes desquamated. And this is the subepithelial tissue, which is acellular, and this is important in the differential diagnosis because the second tumor that looks very much like this is the dermoid cyst. But in the dermoid cyst, you will be finding accessory skin appendages in this particular area. But in the epidermoid, you will not find any accessory skin appendages. The next one. Just to show you the squamous nature of the lesion and the area of keratohyalin granules. The same thing here, you can see this subepithelial layer, which is almost acellular and there's nothing in it, and this the squamous epithelium. The other differential diagnosis usually in these cases from the histologic point of view, where you have squamous epithelium beside the epidermoid and dermoid, is when you have squamous metaplasia in a colloid cyst, and if you have a cystic craniopharyngioma. But it's very easy to make correct diagnosis because every one of them has other features that distinguish them. The keratin, usually you will not be seeing it in craniopharyngioma just like that, or in the colloid cyst. They have a different type of fluid content inside them.
Thank you. Dr. Parsa, do you have anything to add? Do you have anything to add on the histology?
I have one thing to add in histology. You mentioned this is called epidermoid tumor. Actually, we see this, the similar morphology in other parts of the body, and it is, we call it epidermoid cyst. Very similar histology, we see it in the brain. I think the location make it a tumor in this case, while in other locations we call it cyst, and we don't call it in, if you see it in the skin, in the breast, we call it epidermoid cyst. The other things I noticed when I do immuno, the immune staining in the brain, they are cytokeratin 19 positive, while they are not positive in other locations. So probably there is different etiology in both cases, although they have very similar histology.
Thank you. So post-operative course went well, basically. And this is the post-operative second surgery. As you can see, I've done a good job. Infratentorial and supratentorial. And we followed her for a long time. Recently, about 2 weeks ago, she phoned me. She comes from Emirates or Qatar, I don't know. She's Jordanian. She's Syrian, sorry. And this is 14 years after the surgery. She's complaining of absence attacks. For the last 5 years, she's been treated for this absence attack. So I was worried whether she has any recurrence. Anyway, I've sent her for Dr. Khalid Al-Harani. Would you like to come in, Dr. Khalid? Absence attacks, is it epilepsy?
It is. Thank you, Dr. Ibrahim. He's kindly asked me to re-evaluate this case with the possibility of absence seizures. Actually, when I go to the history, the attacks which the patient is describing by herself and by the surroundings, her husband, it is more than absence actually, because the duration of the attack was a little bit longer than absence. Absence usually is seconds, 30 to 40 seconds, the attack. The patient is staring in the space and he's doing nothing, and he suddenly go back to his previous activity with full awareness of what's going on around him. But in this case, the duration of the attack was a little bit longer. It was about 2 to 3 minutes, the duration of the attack. During the attack, the patient was doing an abnormal involuntary movement in her eyes and sometimes with her hands. And after the attack, the patient became confused and she talked nonsense words. And after that, she has a totally amnestic period post the attack, which is not seen in the absence attacks. Usually, the absence attacks is sudden cut off of what's going on around her, and sudden go back to the previous activity. But in this case, it looks like a complex partial seizure more than absence seizure. And the EEG, which I did in my clinic, it showed some sort of slowing in the right temporal area, along with sharp discharges from the same area, which is compatible with the clinical diagnosis or clinical suspicion of complex partial seizure. In this case, actually, even if we thought that the patient is, if we think that the patient has absence seizures, the Tegretol is not the ideal choice. Actually, the Tegretol is not a wide-spectrum anti-epileptic drug. Sometimes the Tegretol, carbamazepine, it can aggravate some sort of seizures like absence seizures and myoclonic type of seizures. So it's not the drug of choice in this case. And we think that the sodium valproate is the drug of choice because it's wide spectrum anti-epileptic drug and it has no history of aggravation of any type of seizures. So we shift the patient from carbamazepine to sodium valproate, and I think she will do okay.
Thank you very much. So, epilepsy is an ocean. No one can grasp it completely except the experts. So I never ever treat patients with anti-epileptic. I am a surgeon, and if the patient has epilepsy, he should go to the neurologist. If the patient has Parkinson, he should go to the neurologist. It is nonsense that a neurosurgeon treats epilepsy and Parkinson, and it is nonsense that a neurologist is treating acute disc prolapse. We asked Dr. Ibrahim Saidat to assess her from the visual point of view.
Good morning. So I evaluated this patient and everything was okay except in this page we don't see much of affection except for this, the last evaluation, which is the visual field. Can we go next? So the visual field is reminiscent of left upper quadrantenopia, basically, which is a visual field that goes more with temporal lobe lesion. And the patient, I remember, she told me that she underwent an operation, and the approach was from behind. So I thought of a temporal or occipital or whatever lobe lesion, and this was also confirmed by the optic nerve head evaluation, which did not show any significant atrophy except in the left eye. But when we evaluated the macula, we found a specific pattern, which is affection of the nasal fibers of the macula here and the temporal fibers of the macula here. So usually I don't see the MRI with the patient. It is usually with Dr. Sbeih. But the patient showed me the MRI, and I figured out that this is an optic tract lesion, and amazingly it did not affect much of the optic nerve. So this is also an atypical presentation of this case. Thank you. So this was the visual field.
Okay. Any patient with a temporal lesion, like this patient, in fact, in 2005, she had an upper quadrantic hemianopia. So this was just a confirmation that she did not progress. And this is the skull X-ray. You can see where we opened in the temporal area, and we range whatsoever. And this is the report from Eid Khakish. The fusion study is unremarkable. So, she was happy, I was happy. This is here just a week ago, maybe 5 days ago, in my clinic here in Rafah Hospital. She insisted on grasping my arm for no good reason. So in conclusion, the epidermoid tumors are very formidable tumors. They are tough tumors. They are sneaky, intelligent criminals. And they should be done by the most senior member of the team. And the aim is total microscopic excision to avoid recurrences and all the things that we have mentioned. With this, I conclude and remind you that next week, before we have any questions from you next week, we'll discuss a case of tuberous sclerosis. Tuberous sclerosis can cause epilepsy in children and can come up with tumors. So it's a very interesting topic. Okay, the floor is open for discussion.
No questions.
No questions, thank you.
Thank you.
See you next Wednesday.
Thank you. يعطيك ألف عافية رائع.
أنا زمان مش من الناس.
هي هذا الفكر كيف يا جماعة؟